Good morning, everybody. Happy Tuesday morning. Welcome to PCH Grand Rounds. We have a, I think, very special and very timely presentation this morning. Our speakers are Dr. Holly Miller from the Division of Oncology and Dr. Cindy Bauer from the Division of Allergy and Immunology. Arizona recently decided to expand its newborn screening program and to include severe combined immunodeficiency. And Dr. Miller and Dr. Bauer wanted to use this venue to explain to us all exactly what this will entail for everybody. So we're excited that they can do this with such a timely, with the Arizona legislature recently making this move. So without further ado, please welcome Dr. Miller.
Good morning, everyone. So as Dr. Olson said, the state of Arizona just passed a law in May to approve newborn screening for severe combined immune deficiency, and we will officially start screening on August 9th. So it's coming up very rapidly. So I'm going to start, I have no disclosures today. I'm going to talk a little bit about the underlying clinical presentation and mortality associated with SCID when left untreated, and learn about the benefits of newborn screening and how TREC assay works for SCID as well as some other disorders, and then discuss the role of community physicians in caring for patients with abnormal newborn screens. So I'm going to start with a case presentation. So this is a patient that came to us in 2015. He presented to us at 3 months of age. He's of Caucasian and Mexican descent. He was born full term, vaginal delivery, no complications with the pregnancy or the delivery itself. His family history was pretty unremarkable, but at 7 weeks of age, he presented to an outside hospital for the first time with cough and upper respiratory symptoms. He was diagnosed with rhinovirus and hospitalized for 3 days and was discharged home. 2 weeks later, he re-presented with still cough and upper respiratory symptoms, and this time was diagnosed with adenovirus infection. This time he was hospitalized for 4 days. Was actually discharged home on 1/8 of a liter of oxygen, which is kind of odd for a full-term newborn. And then at 10 weeks of age, he presented a third time, and this time was diagnosed with otitis media, was treated with a course of amoxicillin. Near the end of his course of antibiotic treatment, he developed a diffuse body rash that initially was attributed to an allergic reaction to amoxicillin. However, even after discontinuation of the amoxicillin, the rash never resolved. At 12 weeks of age, he presented for the 4th time with upper respiratory symptoms and cough, and was diagnosed with multifocal pneumonia. This time he was hospitalized for 1 week, received azithromycin and ceftriaxone, and was discharged home still on oxygen. At 14 weeks of age, he presented with his first fever at this point in time of 102, rhinorrhea, cough, and fussiness. His weight at that point in time, he had gained less than 12 grams per day since birth, was starting to have feeding issues, taking less than an ounce at every single feed. He did receive his 2-month immunizations, including the oral rotavirus, without any difficulties, though. On examination, when he presented here, his vital signs were stable. He actually looked pretty well, other than having some mild tachypnea, really no increased work of breathing other than the tachypnea, and then he had some coarse breath sounds diffusely bilaterally, and then he had this diffuse erythematous rash with areas of peeling throughout his entire body, head to toe. So in the emergency department, they did a CBC, which showed that he had some mild anemia, even for his physiologic nature that he would be expected to have. His absolute lymphocyte count was low. It was 1,600. You really want above 3,000 at this age. And his absolute eosinophil count was pretty elevated at 3,000. You really want it less than 900 at this age. His chemistries were all within the normal limits. However, interestingly, his immunoglobulins, his IgG was significantly decreased for age. His IgG was 80. Keep in mind that there is passive IgG given from mom through the placenta, and so until babies are able to make it, there is a lower nadir for infants, and then that increases with age. His IgM was undetectable, IgA was undetectable, and IgE was elevated for his age. When you look at his chest x-ray on examination, you definitely see this bilateral peribronchial thickening, some hyperinflation in like a left lower lobe opacity. However, it didn't look too terrible when he presented. His respiratory PCR was positive for adenovirus and enterovirus. So this is like the third time this kid has had a positive adenovirus on screen starting at about 10 weeks of age, and so now he's 3 months. So in the emergency department, immediately people were confused that this, or concerned that this kid may have an immune deficiency. So immunology was consulted from the ED, and they placed the patient immediately in a reverse isolation room, and SCID precautions were in place until the workup was completed. So at the time, he also received CMV safe irradiated blood, so that we're not giving him any risk of developing a CMV infection and decreasing his risk for developing transfusion-associated GVHD, which SCID patients are at risk about, and I'll explain later. He also received IVIG upon admission because he was having some issues clearing viruses, and his immunoglobulin level was only 80. He was started on broad-spectrum antibiotics while blood cultures were obtained and pending. And then he was started on Bactrim prophylaxis because of his low absolute lymphocyte count. So because of the initial lab work that was obtained that was abnormal, we decided to do a lymphocyte subset panel on him. His CD3 count was low at 1,300. CD4 was also low at 1,060. CD8 was low, and CD19 or B cells were absolutely absent in him, and his NK cells were pretty elevated. We also look at markers for CD4, CD45, RA, and RO. These look at naive and mature T cells. And his naive T cells, the RA cells, were found to be pretty low with significantly elevated RO T cells. We also did, at this time, we weren't doing newborn screening in the state of Arizona outside the Navajo Nations. And so we sent a TREC assay, which stands for T-cell receptor excision circles, on him, which came back less than 5, which is below the limit of detection, so very abnormal. We also sent lymphocyte response to mitogens. The most important mitogen that patients with SCID tend to have is PHA, which really, when it's less than 0.1, it's completely absent. 0.1 to 0.3 is very low. And his PHA response returned pretty low. His infectious studies also showed that he had a blood culture that was positive for MSSA. His BAL was positive for PJP pneumonia. And his adeno-PCR virus in his blood, in addition to the respiratory virus panel that we did on admission, showed 1.8 million copies. So he had several infections and was actually pretty sick, despite him not outwardly looking as sick as he really was. He was ultimately diagnosed with T negative, B negative, NK positive SCID, and so we sent genetic testing to confirm his genetic diagnosis. Fortunately, this takes about 42 days to process, and so it's a long turnaround time. There are some SCID patients that have radiosensitivity, so it is important to know their genetic moniker that they have involved in their SCID. He ended up being positive for REG2 mutation, which is a type of NK positive SCID. Unfortunately, because he came in with multiple infections, we required aggressive control of those infections. So he was treated with IV Bactrim for management of his PJP pneumonia and his MSSA. Unfortunately, his adenovirus was not responsive to cidofovir or brincidofovir, and so he was actually treated twice for adenovirus-specific cytotoxic T lymphocytes through Children's National Hospital. And for management of his enterovirus and rhinovirus, we basically just gave IVIG support. So I don't know if any of you guys know who this is, but this is David Better. He's probably the most infamous patient ever diagnosed with SCID. So David Better was born in the 1970s. He was the third child of the family. The first child was also a male who died at 7 months of age due to SCID. The second person in the family was a female. It was found that the older brother actually had an X-linked version of SCID. And so when they found out that their third child was in fact male, he was literally born and within an hour placed into this bubble, for all intents and purposes, that was created by NASA. And there he grew and lived for about 12 years until he finally underwent stem cell transplant. Unfortunately, a couple months after transplant, he developed lymphoma and ended up passing away. But he lived for 12 years, which was unheard of at the time without stem cell transplant. So what is SCID? SCID stands for Severe Combined Immunodeficiency. It occurs in approximately 1 in 55,000 live births, and this is based off of data that we have from states who already do newborn screening. Previously, we felt that the incidence was about 1 in 100,000. We feel that many patients probably died due to overwhelming infection prior to their diagnosis, or deaths were attributed to sudden infant death syndrome previously. There's definitely a higher incidence in cultures with consanguineous marriage. So, for example, the Artemis mutation in Navajo nations is approximately 1 in 2,000 to 1 in 3,000 live births. They typically present in infancy with failure to thrive, recurrent severe and/or atypical infections, and chronic diarrhea. So that brings me to the first question. Which immunodeficiency is completely asymptomatic at birth? And I'm going to give you a second to log into the MOC and poll everyone. So the options are Bruton's agamma-globulinemia, severe combined immune deficiency, hyper-IgM syndrome, and ataxia telangiectasia, or E, all of the above. It seems that most people went with all of the above, and that's actually the correct answer. So like I said before, all term infants are going to have passive immunoglobulin received from the mom through the placenta. And so basically anyone who has a primary antibody deficiency as part of their immune deficiency is going to be completely asymptomatic at birth. So for example, 50% of patients with Bruton's may have symptoms by 1 year of age. However, unfortunately, the average diagnosis is about 5.4 years. So they tend to have pretty mild symptoms that progress over time. It may be earlier in patients that have family history, but even in family history, the average age of diagnosis is 2.4 years, which is still pretty late for someone that you know already is predisposed to have it. Again, SCID typically has infectious symptoms starting around 3 months of age, but they can go as late as 12 months of age to be diagnosed in the absence of newborn screening. X-linked hyper-IgM typically presents around 6 months of age, usually with PJP pneumonia as their first presenting symptom. However, the autosomal recessive hyper-IgM syndromes can present much later in life, usually around 2 to 5 years of age. And then many children with ataxia telangiectasia appear healthy for the first year of life. Usually their first presenting symptom is the ataxia, as the evolution of the immune deficiency component of it is an evolving process. So what is SCID? So like I said, symptoms are not immediately present at birth due to maternal antibody protection. Unfortunately, it's universally fatal by 2 years of age if left untreated. They have an absence of both cellular and humoral immunity. So you often see common infections such as otitis media, pneumonias, and viral infections. Unfortunately, the viral infections are usually fatal in this patient population because they don't have the cells they need to help treat it. We don't have good antivirals. You can also have opportunistic infections such as persistent or recurrent mucocutaneous candidiasis, PJP pneumonia, mycobacterial infections, as well as fungal infections. And then you can also have infections due to live attenuated vaccines. Previously, we didn't have any live vaccines until the 12-month mark when patients were receiving their MMR or VZV vaccine. However, with the rotavirus vaccine that was made several years ago, we're now introducing live attenuated vaccines at 2 months of age. There's been several patients with severe combined immune deficiency who've been documented to have chronic rotavirus infections. So when we have a patient with suspected SCID, we want to do further evaluation. So your evaluation will always include a CBC with differential. The absolute lymphocyte count is typically less than 2,500. And you want to do a T-cell mitogen response. So there's really two types of SCID. There's classic SCID and what we call leaky SCID. So classic SCID, you're going to have near absence of those autologous CD3 cells, less than 300 per microliter, with an absent PHA less than 10%. And then your leaky SCID is going to be typically less than 1,500 per microliter with 10 to 30% PHA. There are some caveats to that, which does make this diagnosis sometimes more confusing, where you can have maternal engraftment, where the maternal lymphocytes actually are within the infant itself. And so that's why I make this point to say autologous T cells, because in the presence of maternal engraftment, you can actually have a normal appearing lymphocyte count. And then in leaky SCID, you can have something called Omen syndrome, where these T cells, you basically have one type of T cell that goes rogue and undergoes oligoclonal proliferation, which then, again, makes a normal-looking CD3 count. The naive T cells, however, are going to be low or absent, again, with this poor diversity, because you do have oligoclonal proliferation to some extent. Hypogammaglobulinemia is going to be common. However, in patients who are caught by newborn screen, usually they still have normal IgG levels at that point in time. And then their specific antibody responses are going to be severely impaired for kids that are old enough to undergo that testing. When you do a chest x-ray, you're going to see an absent thymic shadow. So here on the left, you can see a normal thymic shadow. It's nice and big, takes up 2/3 of the diameter of the chest, and on the right you see nothing there. There's several different classifications of SCID. They're all going to be T negative, as you can see here. However, you can sometimes have the presence of B cells and or NK cells. There's really only one type of SCID that's going to be T negative, B negative, and NK negative. That's ADA deficient SCID. And then there's only one X-linked gene, which is a T negative, B positive, NK negative, and this is a common gamma chain deletion. So prior to newborn screening, most kids were diagnosed either off of family history or once they had severe symptoms. We previously thought that the X-linked SCID was the most common, with about 50% of cases being X-linked SCID. With very few reg mutations, as you can see here, only about 1% of patients had reg1 mutations. After the first 11 states started doing newborn screening, every state sat down and looked at the different genetics that they have identified in their SCID patients that they found on newborn screening. We found that actually a lot less had this X-linked SCID. There's a lot more of these reg mutations that we're seeing. And the reason for this is, unfortunately, reg mutations often have a leaky SCID phenotype. So again, they tend to not have a severe clinical phenotype up front. However, the ultimate outcome is still the same, with dying eventually if left untreated. And then with the advent of newborn screening, we're finding a lot more of these patients also have unknown or unspecified genetic defects as well that we just haven't discovered yet. So how do we manage SCID? So there's several precautions that we have to put in place when we have a suspected SCID diagnosis. The first thing we want to do, which is always hard as a pediatrician to ask mothers to do, is ask the parents to hold on breastfeeding until a SCID diagnosis is confirmed. They may continue to pump and freeze their breast milk in the interim so that they don't lose that breast milk production. However, if the mom does come back CMV negative, you may consider continuation of breastfeeding at that point in time. The biggest risk from breastfeeding is giving SCID patients CMV infection, which does cause a high mortality rate in these patients. We want to avoid any live vaccine administration. So with them not having an immune system, they don't have any immune response anyway to even the inactivated vaccines, but the inactivated vaccines fortunately don't cause any harm. Unfortunately, the live vaccines do. So if you have a suspected SCID, hold on the rotavirus vaccine. And then they all need to be started on prophylaxis. So we want to help protect against opportunistic infections. So we put them on Bactrim or atovaquone for PJP prophylaxis, fluconazole for fungal prophylaxis, acyclovir for viral. And then we want to support their IgG with IVIG. And then if they are born during the winter, we want to help prevent RSV because this is another major cause of mortality. So we give palivizumab monthly during RSV season. Some of the complications we can see with SCID, which I already briefly mentioned, include maternal engraftment. This can occur in up to about 40% of patients. This is where the maternal lymphocytes that are transferred placentally end up taking host inside the body. So because they don't have an immune deficiency, they're essentially getting a transplant from their mother without getting a full transplant. Unfortunately, these lymphocytes go unchecked and can cause a lot of problems in our patients. So like I said before, this may cause the T cell count to appear normal. However, the T cells that are there are energized, so they have no activity at all. And because they don't have any activity, they end up having this illegal clonal proliferation and can cause problems similar to what we see in chronic graft versus host disease following stem cell transplantation. So you get this eczematous rash similar to what our patient had. They have eosinophilia similar to what our patient had. They can also develop splenomegaly. You can also have transfusion-associated graft versus host disease. So unfortunately, a lot of blood products do contain some small amount of lymphocytes within them. And these viable lymphocytes may cause fatal graft versus host disease in patients who are pre-transplant with SCID. And so how do we prevent this? We prevent it by irradiating and leukodepleting all blood products prior to giving transfusion. We also want to administer CMV-safe blood products so that we don't increase the risk of CMV infection. And then you can also have something called Omen syndrome. Typically, you see this in this T negative, B negative, NK positive SCID. Particularly the RAG mutations seem particularly susceptible. Clinical features are due to activated T cells that have a limited repertoire and dysregulated B cells. Again, symptoms appear very similar to that maternal engraftment that I talked about with chronic GVHD appearing symptoms with splenomegaly, lymphadenopathy, eczematous rash, and eosinophilia. So if you have someone who presents with any of these symptoms, you need to rule out maternal engraftment. The way we do that is we take a cheek swab from the baby, a cheek swab from the mom, and a blood draw from the mom, and we look to see if any of mom's cells are in the baby's blood. And it takes about a week to come back, and if you don't see any maternal cells, then you know that you have Omen syndrome and not maternal engraftment, and that's how we differentiate between the two. Can SCID be cured? Yes, it can. The curative treatment for SCID is hematopoietic stem cell transplant, or HCT. There is a significantly better survival when transplant occurs in the absence of infection, and an improved survival when transplant occurs at a younger age. So the biggest study came out in 2014 by Sung-Young Pai and others that looked at the age cutoff and infection status undergoing transplant. Patients that are transplanted less than 3 months of age, 3.5 months of age, who have never had any infection have about a 95% chance of surviving stem cell transplantation, regardless of donor source, regardless of conditioning regimen, any of the other complications that we tend to consider in transplant, they're irrelevant. Patients who are greater than 3.5 months of age but have had no infection prior to transplant, their survival isn't that much different than the less than the 3.5 months of age, and so it seems to play a huge role here. Now, the patients who are greater than 3.5 months of age who have an infection that resolved prior to transplant, there is a significant difference in survivability. It's about 80% in those patients. And unfortunately, patients who have active infection at the time of transplant, their survival is less than 50%. And so That's why newborn screening is really important, because we can identify these children at about a week of age to see if they do have SCID, put them in those protections to try and prevent these infections, and then give them a transplant. The goal is less than 3 months of age. So looking at it further, when they have no active infection at the type of transplant, like I said, the stem cell source doesn't really matter. So we have matched sibling donor, which the survivability is 100%. But when you look at even doing like mismatch related donors, where they're only going to have 50% of their genes matching prior to undergoing stem cell transplant, the difference is not statistically significant between the two of them. However, when you do have an active infection at the time of transplant, matched sibling donor still has a great survivability at about 90%. However, when you have any other donor source, you can see that they're all around the 40 to 60 percentile in regards to survival. Unfortunately, when they do have an active infection, we really have to try and avoid giving conditioning regimens to these patients to try and get those new stem cells to come in. And therefore, especially patients that have NK positive SCID, they are at higher risk of rejection because of that. I'm not going to go into too much specifics and make this a transplant talk, though, because I could spend a whole hour on transplantation in SCID. Also, looking at the dollars and cents of transplant, when you have a patient that has an active infection prior to presenting versus no active infection prior to presentation and their age. This was a study that Rebecca Buckley did out of Duke, which North Carolina only just started doing their SCID screening. So this was a study that was about 15 years long that she did, looking at the cost of transplant in patients who presented less than 5 months of age and greater than 5 months of age. You can see that the cost of transplant for patients less than 5 months of age was about $100,000, whereas the patients who were greater than 3 months of age, 3.5 months of age, the cost of transplant was about $500,000. And this is because of all the complications that the older the patients get, you have to deal with prior to even getting them healthy enough to undergo a transplant. So it's not even just a survivability issue, it's a healthcare cost issue too. So in 1968, the WHO came out with principles on screening for medical conditions and what they really recommend in doing newborn screening. And so I have on the left here all the statements that the WHO recommends for anything that should be part of newborn screening. So firstly, the condition should be an important medical health problem. And I believe SCID is important because it is universally fatal if left untreated by 2 years of age. There should be treatment for the condition. Yes, I just explained that the treatment is bone marrow transplant. There should be a latent stage of the disease. We've already discussed that. Patients are asymptomatic till about 2 to 3 months of age when maternal antibodies are no longer protecting the infants. There should be a test or examination for the condition. There is TREC screening, with the positive predictive value of TREC screening for SCID and T-cell lymphopenia being about 45.83%, which is a much better positive predictive value than any other test on the newborn screening panel. And the tests should be acceptable to the population. So in 2010, the recommended uniform screening panel was updated to include SCID screening. So we are now in 2017. We're just getting on board 7 years later. So a little bit of a delay. So this is a map of newborn screening across the United States who are already looking at SCID. All 6 U.S. territories have already been screening for SCID, and we are one of the last 3 states to turn purple. Fortunately, we are going to be one of the shortest states to be in the purple phase because our implementation period was about 3 months from getting approval to do it to starting screening. There's only 2 states that are not in the process of screening or talking about screening, and those 2 states are Indiana and Louisiana. So a little bit of work to do, but not that much work.
So the 2 states have something in common that might cause you to feel that way?
So, you know, Indiana actually has a large-ish Amish population, so they would actually benefit from having SCID screening in their state. They have a higher incidence of it in that community because of the consanguineous marriage. Louisiana actually at one point in time did have SCID screening. They, in 2009, had a pilot that was going on, but by 2011, they ran out of money and they haven't been screening ever since. So they were someone who had benefited temporarily from it. So I don't understand why they are not picking it back up. I think a lot of it just deals with state funding. So looking at newborn screening specifically in Arizona, currently we only do SCID screening for patients who are born on the Navajo reservation itself or are seeing a reservation doc on the reservation. We will start screening statewide on August 9th, 2017. Like I said, nationally, the estimated incidence of SCID is about 1 in 55,000. However, in our state population, we have a unique population here where we have significant Athabascan population. So not only the Navajo, but the Apache, the Hopi are also at risk of having SCID as well. And the incidence within the Athabascan population is about 1 to 2 to 1 in 3,000 within them. Also, the Hispanic population has a risk of SCID at approximately 1 in 22,000 live births. They tend to have reg mutations, whereas the Native American tend to have this Artemis type SCID. And so with our population here within the state of Arizona, we anticipate that we're going to have higher incidence than this 1 in 55,000. We anticipate that there's going to be about 2 diagnoses of SCID per year throughout the state. So how do we screen for SCID? So it's done by the heel stick, done at 24 hours of age. Basically, what we do is we run the heel stick via flow cytometry, and we look for these things called T-cell receptor excision circles, or TRECs, as you can see right here. So how we get TRECs is by the maturation of lymphocytes. So if we're able to make mature lymphocytes through our thymus, then we're able to make TRECs. If it's normal, there's no further action needed. If it's abnormal, however, we need to do confirmatory testing and consult with an immunologist. So like I said, TRECs stand for T-cell receptor excision circles. It's a nice biomarker for newly produced naive T-cells and a marker for thymic production. So what happens when T-cells mature, they undergo non-homologous end joining through VDR recombination. And when this material here is excised through VDR recombination, it ends up making a circle upon itself. And so 70% of your alpha beta T cells are able to make those TREC cells, which is nice because that's what makes it such a good marker for patients with severe combined immune deficiency. So, like I said, how is a TREC itself made? So in the bone marrow, we're making all of our blood cells, red blood cells, white blood cells, and platelets. However, they need to undergo some education. So especially the lymphocytes, they end up making their way to the thymus to get their education. And in the thymus, they are educated to recognize self versus non-self. So that's where that Omen syndrome comes into play and the maternal GVHD comes into play because they don't have a thymus doing that education. So they don't have this capability to do this self versus non-self. And then eventually they graduate from the thymus. And really, once they complete their education and recognize self versus non-self, that's when they make their TRECs. Okay. So this brings me to question number 2. Low levels of TRECs can be found in which of the following conditions? A, only SCID. B, SCID in 22q11.2 deletion. SCID 22q11.2 deletion, as well as trisomy 21, or SCID 22q11.2, trisomy, and protein-losing enteropathies. So the correct answer here is D. And so the rationale, since TRECs are byproducts of T-cell maturation, they identify patients with low T-cell production. So patients with SCID, we already talked about, they can have low T-cell production. 22q11.2 deletion, or DeGeorge syndrome, they also have variable T-cell lymphopenia. So it can help identify those patients who may not have a significant cardiac defect and just might have a mild ASD. And then trisomy 21 can actually present with variable T-cell impairment as well at birth. Finally, protein-losing enteropathies allow the loss of both T-cells, causing T-cell lymphopenia, as well as TRECs through the GI tract. So they have a normal production, however, they have increased loss, and so they can also be picked up on newborn screening with a TREC assay. Other implications of TREC. So, like I said, low TRECs can identify T-cell lymphopenias as well. We found in California that the incidence of T-cell lymphopenia is about 1 in 19,000 live births. Fortunately, they may not require transplant for cure, and some of them may just be transient and non-problematic. However, the nice thing is it can identify these patients early that still do need some intervention or treatment. There's also multi-system syndromes that have T-cell lymphopenias, such as DeGeorge syndrome, trisomy 21, ataxia telangiectasia, and CHARGE syndrome. You can have secondary T-cell lymphopenias, so from congenital cardiac anomalies. You can have vascular leakage or third spacing in patients with high drops. And then neonatal leukemia can also cause T-cell lymphopenia as well. Protein-losing enteropathies, like I said, you have normal production but increased losses. And then you can have transient T-cell lymphopenia. This is most common in preterm infants. However, it normalizes typically around 37 weeks of corrected gestational age. Unfortunately, TRECs are not perfect. There's still some T-cell deficiencies that will have normal TREC assays, such as ZAP70 deficiency, MHC class II deficiency, X-linked hyper-IgM, Wiska-Aldrich, and HIV and AIDS, which ironically was the original reason why TREC assays were created, was to aid in doing a secondary test in patients with HIV. And then some immunodeficiencies really aren't present at birth and just develop as time goes on, such as combined variable immune deficiency. So going back to our patient, during the first week of his admission, unfortunately his rash worsened, covering 100% of his body with desquamation over 100% as well. He developed diffuse lymphadenopathy and hepatosplenomegaly with worsening respiratory status. And so at that point in time, we were concerned for maternal engraftment versus Omenn syndrome. So we did the chimerism testing, cheek swab and blood draw, and it showed that they were 100% patient cells. And so we ended up diagnosing him with Omenn syndrome, and we treated him with immune suppression via cyclosporin. With the treatment of his Omenn syndrome, his T cells decreased to an absolute CD3 count of 203. So like I said, one of the findings that you have is an autologous CD3 count of less than 300. His rash resolved, his lymphadenopathy and hepatosplenomegaly all resolved as well. Because of his active viremia at the time of his first transplant, we were unable to give him conditioning, so he underwent a 10 out of 10 matched unrelated donor transplant with a great cell dose. His CD3 count initially rose after transplant, however, by day 46, he lost his graft. Despite his transplant not being successful, he was finally able to clear his adenovirus infection prior to proceeding to his second transplant. We believe that this is likely due to his CTL infusions that he received in combination with some transient immunity that he had from his first transplant. And so this just looks at his adenovirus in his plasma, his stool, and his urine. You can see, despite giving brincidofovir and cidofovir, he really didn't have any response in his adenoviral copies. He got his first infusion of his CTLs mid-October, however, didn't have, again, any response. And so we decided to do his first transplant in November, just after his second set of cell infusion. And with the transient immunity that we had around 1 month out, and with the CTLs that he had infused the second time, you can see that all the copies became negative about 2 months out from his first transplant. So he ended up undergoing a second transplant with reduced conditioning, reduced intensity conditioning on February 22nd, 2016. Again, with a good cell dose, he engrafted his white cells very early on day plus 14. By day 28, he pretty much had 100% donor chimerism, pretty close to it. He was discharged on day 36 following his second transplant, which was admit day 227. So he was admitted for 9 months, mostly for controlling his infections, and on day 36, after his second transplant, he was discharged home. Since hospital discharge, he's actually doing great. He's off immunosuppression. He is going to start preschool this fall. He is making his own TRECs now. His TRECs are still lower than what you would expect for someone his age. However, he's making them, and they are getting closer to the normal range every single time we check them. He's no longer requiring any IV immunoglobulin, and he's receiving all of his immunizations without any issues. So going back a little bit further about Arizona and SCID, so Native Americans of the Athapascan descent have a higher incidence of SCID due to the founder effect. So it's about 1 in 2,000 and 1 in 3,000. They typically have this Artemis SCID, which does have radiation sensitivity associated with it. So we really need to try and avoid chemotherapy in these patients. When patients do have chemotherapy given to them with transplant, they have absent tooth development, growth retardation, and hormonal defects. So it is important to know what type of SCID they have, and it's important to know what their background is. Unfortunately, it's also tricky to find good donors in this Native population, so they often benefit from haploidentical transplants. However, they do have a high risk of rejection because they do have NK cells, which does increase their risk of rejection. We're not allowed to give them chemotherapy. Well, we try and avoid giving them chemotherapy. Unfortunately, we can't always avoid giving chemotherapy to these patients, but if we keep them healthy, identify them early, you can limp along until you get that graft in. So I'm going to turn this over to Dr. Cindy Bauer to talk about how PCH has, what we've done to prepare for newborn screening.
Thank you very much. So, as you can imagine, we have been working on this for quite some time and are extremely excited for August 9th to roll around. One of the major things we knew that needed to be developed was to have the clinical infrastructure in place. And in so doing, we created an Immunohematology Clinic. Likewise, we needed to make sure that we had the appropriate testing available, not only here at Phoenix Children's, but via send-out testing and at the state as well. As far as the Immunohematology Clinic, this clinic began in December 2016. It is staffed by Transplant, really Dr. Miller, and Allergy Immunology, either Dr. Wright or myself. The clinic is twice a month, and in the first 7 clinics, we analyzed our patients and realized that 2/3 of them had presented to more than 5 subspecialists prior to their consult. So these are very medically complex patients that don't have often a home for their primary immune deficiency. We already had 1 patient that we saw that subsequently went allogeneic transplantation, and 6 for which we were considering transplant once we had a molecular diagnosis finalized. 5 patients that we had seen benefited from immune modulation therapy or other immunotherapy. This is a slide that is not meant to be read, but just for you to understand that the world of primary immune deficiency is ever growing. Just like Dr. Miller said, with the new genes that we expect to discover causing SCID, we're discovering new genes that cause new diseases literally every day. These are diagnoses we have seen here at Phoenix Children's Hospital, and that first one off already is extremely, extremely rare. So again, I think it's, maybe we're biased, but I think it's really exciting for Phoenix Children's to finally have an immunohematology clinic, or a primary immune deficiency clinic, which was its original name, but no one liked it when I called it the PID clinic. So, PCH has prepared an edition by creating handouts, algorithms, and checklists. And this is where I'm going to assume many of you are in primary care because that's kind of the target audience for today's talk. So with that said, we've created a 3-page frequently asked question FAQ for primary care physicians that will come from the state when you have a baby with an abnormal newborn screen. We hope that the FAQ can answer most of the questions you have. And we've modeled the FAQ after cystic fibrosis with the help of Dana Valletta, who has a wonderful program for CF screening here in our state. We also have created a pamphlet for families that the state will also be sending directly to families, answering hopefully many of their common questions about what is this TREC assay testing for, what does this mean, what do I do, what do I not do. This is still being edited. We have to make sure it's user-friendly enough. Algorithms have been a huge thing that we've been working on, and this is tentatively where we're at right now. So the state is going to be using a TREC assay through Perk and Elmer, and they recommend starting with a cutoff of 25. However, we will likely modify this cutoff once we begin newborn screening. So for now, if it's less than 25, we need to assess that the test is of good integrity, so the DNA template integrity, and we do that with beta-actin. If the beta-actin level is normal but the TRECs are low, then we probably have a problem, versus if it's a crappy test, then the beta-actin will be low and the TREC will be low, and maybe you just want to repeat it before setting off an alarm. If TRECs are abnormal, we will then determine if it's critical. When you look at SCID, particularly in the Native American population and in really any SCID, it's often 0, 1, 2. It's extremely low. So while we haven't finalized that cutoff, and it may not remain 6 forever, it may go up or down, but we do know that there is likely to be a value we can determine to be critical, and we will treat those children very differently. As a first step in the community, you will still, regardless of critical or not, be the first person to talk to those families because you know them and they don't know us at all. So you'll make the phone call. However, if the value is critical, we will also call the family as well, and we will arrange to see them. And likely we will, or another specialist that can work with us, depending upon where they live in the state, we will obtain the confirmatory testing. So what about preterm infants? Oh, sorry. Is the TREC assay validated in preterm infants? Sorry. And for the sake of time, I'll just take a couple answers. Yes, it's a leading question, and so no, it's not validated. So basically, as you know, since Dr. Miller mentioned it, the newborn screen is obtained at a set time, and while we would like to request that our assay not be obtained until their 37 weeks gestation, there's no way to do that since it's a panel. So we're going to get stuck, and we knew that. So we have attempted to create an algorithm to accommodate for that. And going forward, hopefully we can work with the NICUs and others to make this as smooth as possible of a process. Because very likely they may be low in the preterm baby. Again, if they're low, we assess the DNA template integrity. If that's normal, what we would then do is, again, have a cutoff for critical. But if they're anywhere low but not critical, it could just be because of their gestational age. And in that case, we would like those babies monitored with a repeat obtained at 37 weeks gestation or at hospital discharge, which again, depending upon when that is, if it's less than 37 weeks, I suppose could put us back in a tricky spot where we can't interpret it. Borderline TRECs, we will obtain lymphocyte subset analyses on, and abnormal or critical, of course, is seen in the Immunohematology Clinic. This is a couple of slides that summarize a checklist that we've created. I think on the piece of paper, it's much cleaner than in a presentation. But we hope that when you call those families and see them to obtain the confirmatory testing, because the TREC is just the screen, we really need that lymphocyte enumeration where they spell out this CD3, CD4, CD8, NK, so we can determine what this really is, if it is SCID at all. So in that visit, this checklist should make it easy for you. So you're going to now be able to tell them, again, what is TREC screening, what is SCID, what are you looking for? Now you can understand why we don't want them to breastfeed, and explain, you know, don't dump it. You still might be able to use it for your baby. Just give us some time to complete this workup, and in the meantime, use boiled water. You get it all. Dr. Miller talked to you about live vaccines, and you can talk to mom about how you're going to be cautious during the next couple weeks while this workup is finished. You'll also want to do an assessment of their home situation, and in fact, if this comes up on the phone, that's perfectly fine as well. The key here is they're at high risk for infection, and their home should be reverse isolation, right? But sometimes in these instances specifically, the home is actually worse. And in that case, even though the hospital is loaded with infections, we'd actually prefer to have them here in isolation. Hope that makes sense. So we depend upon you to assess their home, and of course transportation is part of that. If they live far away and are unlikely to be able to get here back and forth, or any such questions remain, we'd rather just have them here. So again, if there are any concerns in the home or transportation, we would have a low threshold to just admit the child while we complete this workup. It's too risky otherwise. But if the home seems okay, then there's a few more basic things that you would want to convey to them about what to do if the baby gets fever, hygiene, visitors, not going in public places. When they're seen by either the primary care or even an urgent care or ED, make sure they call ahead or let someone know, and don't hang out in the waiting room. They should be seen right away. The last one is a little tricky. If they're school-aged children, we just need the school ideally to know that this is going on, such that if varicella or chickenpox is seen in the school, that baby with possible SCID can be treated accordingly. So again, a little confusing checklist, but it's better on the sheet we're creating. We need the primary care physician to put the referral in for the Immunohematology Clinic, because regardless of what the confirmatory testing shows, whether they have SCID or not, we will see them at least one time. Obviously, if it's not SCID, we have a little more wiggle room of how urgently to see them, but we still will see them to make sure that their immune system is functioning appropriately, and what role, if any, we have. As Dr. Miller said, we expect to pick up quite a few DeGeorge patients. Fortunately, we have a DeGeorge clinic, and we can send them onward and educate them on what immune deficiency, mild likely, that they may have in that, and so on and so forth. So we'll get them in the right place. The confirmatory testing should be extremely straightforward for you in the primary care setting. We have the paperwork all sent, or all filled out, and that will be faxed with you as well. We really just need the blood, and we need it as soon as you can possibly get it. Like literally, if you can see that child that day or the next day. We had a kind of a pilot case not that long ago where a baby was born at a hospital off the reservation, but then went home where they lived on a reservation, had a follow-up with their doc on the reservation, and so got a TREC screen a little late, but indirectly through their primary care. And then the baby did circle into our system and ended up not being SCID, but ended up being a very, very, very severe and potentially fatal diagnosis. In the Immunohematology Clinic, if the value is critical, we'll see the baby, we'll take care of the checklist, and we'll also start those infection prophylaxis medications that Dr. Miller already talked about. And I wanted 5 minutes, so we have 5 minutes for questions. But basically, this is our newborn screening in the state of Arizona, and I'm really excited, as you all should be, that we're the 48th state to screen for severe combined immunodeficiency. In 2007, Wisconsin was the first state to screen for SCID, and I was there. And so my fear was that I would be in the first state when they screened and in the last state when they screened, but we're not. We're 48, and I'm really proud of Arizona, because actually in the last year, it came together quite quickly. And with that said, we definitely have to thank several people for this happening. Obviously, our partners, Dr. Wright, who is a core member of our Immunohematology Clinic team, Dr. Adams, who has given us wonderful mentorship and oversight, and then our nurse coordinator, who is definitely someone you can reach out to with questions, concerns, scheduling, anything like that, and that's Krista. The state, and we have someone from the state here today, Fran, has been instrumental and is working so hard to get this ready by August 9th. Not listed here, though, would be the March of Dimes, SCID Angels, and there were some families with SCID that testified with us, and as a team, we all worked together, and obviously it's been successful. So I hope you're excited and willing and ready to screen for SCID. Are there any questions that we can answer for you today? Yes.
Thank you for your talk. Just two quick questions. One, do you guys do inpatient consults at all? And two, is the focus of the Immunohematology Clinic patients that will eventually need bone marrow transplant, or is it kind of all primary immunodeficiency, less severe primary?
Yeah. So the Immunohematology Clinic is meant for any primary immunodeficiency. Occasionally we can see those with secondary immunodeficiencies, but we're pretty strict in screening who gets in. So if you're not sure, you can always reach out to one of us. But no, not all primary immunodeficiencies are meant to be transplanted, but a lot are. And I guess that was just something that was an interesting factoid. But no, like common variable immunodeficiency, we don't transplant. The child with the Mendelian susceptibility to mycobacterial disease, he's on interferon gamma treatment to clear mycobacterium. So it just depends on the immune deficiency. And
Yeah, so primary immune deficiency just happens to be an interest of mine outside of transplant. So I actually did a year of training during my fellowship in immune deficiency disorders. And so even though, yes, I am a transplanter by trade, I do have an interest in the immunodeficiencies. And sometimes it's nice because as a hematologist, I add a different spin to working up and evaluating these patients than, the immunologists do. And so what's nice as a group, because we see these patients together, you have 2 heads are always better than 1, 3 is better than 1. And so we talk about every single patient together that we see. And so it's really nice. And actually, especially the Mendelian susceptibility patient, he's had symptoms since age 1.5, and he's 5. And so he went undiagnosed for 4 years of having symptoms. And so it's just one of those things that literally the first time we saw him, we're like, this is what you have. And it's so funny that it actually came that. But I mean, like I said, 3 heads are better than 1. So
yes, so yes,
yeah,
Dr.
so
Miller.
That would be me.
All over it. But as she alluded to, while she may be physically the only one seeing your patient, you will have a team assessing that baby if it's a primary immunodeficiency, because they're too rare for any one person to stay up on. Yes?
You showed a slide of early versus late transplant. What about transplant patients versus non-transplant patients? What's the process?
They die.
Oh, they die. So it's universally fatal by 2 years of age. So far, there's only one type of SCID that can be treated with enzyme replacement therapy. That's ADA deficient SCID. There are a couple other enzyme replacement therapies in early development that are in like phase 1 trials. However, still the mainstay of therapy is transplant. A lot of patients that do fail enzyme replacement therapy with ADA SCID still end up needing transplant as well.
And those costs were big selling features, I think, when we made our case. So it's about $6 per TREC assay, but you can imagine the prolonged hospital stays of the parents who testified, and when they state their total bill, we're talking millions, which would have covered screening for the whole state for years. So yeah, no, good question on cost. Well, we'll be up here if you have any other questions. We look forward to working with you. Thank you.